we did some polling from all of our hospitals, nursing homes, healthcare facilities. They felt that they wanted to form a community. And that's exactly what we did. And the community has included mostly professionals, but retired individuals, students, anyone who has a strong interest in bioethics. And we've been involved in a lot of different projects over the years, not to mention creating two model policies that address non-beneficial treatment. One most recently developed last year that was shared and now is being used by all of our hospitals, or at least they know that they can use this model policy. And it was something that we actually had a request from the chief medical officer group in the county of San Diego to develop this. Anyway, I could go on, but welcome everybody, and you're in the right place if you're here to learn more about ethical issues related to monoclonal antibodies for the treatment of dementia. So I'm going to hand this off to both Dr. Tomita and Dr. Cedarquist for any opening comments and then an introduction to our speakers. And also, if you could maybe just put in the chat your name and where you're from. How's that?
By where you're from, you don't mean where you were born, but where you work now.
Yeah, like it could be your garage, your bedroom, the hospital, whatever.
I'll go ahead and just to introduce myself for people that don't know me. So I'm Lynette Cedarquist, the other co-founder with Paula with this at Commission. I'm the director of the clinical ethics program at UCSD and have really enjoyed this opportunity to be able to connect with others in the community. We all get in our little institutional silos. And so this has been a really nice way to network within the community. So, and Paula, can I make a quick announcement while we're on, or do you want to save announcements to the end? You're muted.
Yeah, that's fine. If anyone else has announcements also, we can,
or I can do it after Mitz introduces himself so I don't get us off track.
Okay, well then briefly, Mitz Tomita, retired family practice, Kaiser Permanente, and I've been kind of co-chair with Paula for the BioEthics Commission for a number of years. That's all I have to say. Oh, except that I'll be working on, this is being recorded and I'll have to mute people if they don't come in on mute.
Well, the other thing we can say about Dr. Tomita, he is really good at shepherding and collecting good speakers and people. And we thank Dr. Tomita for finding our fabulous speakers. So I'm not going to introduce them. I would like Mitz to, but I guess in the meantime, does anyone have any announcements they wanted to make from anyone on the call? Related to the bioethics community, that is, yeah.
Yeah, can I announce something that's coming up? If it's okay, yes. Can I screen share just to show a flyer?
Sure.
And then we'll send it out just real quick. Sorry. And I see Faye is on, so that's great. So February 7th, we're having the inaugural endowed lectureship, the Faye Gersh endowed lectureship. Which we're fortunate to have Faye endowed to UCSD School of Medicine. And this is open to anybody. It's going to be Dr. Lonnie Shavelson, the founder of our American Clinicians Academy on Medical Aid and Dying, has really become a national leader in this realm. So we're very happy to have him coming. I will send this flyer out, but I just wanted to have just kind of flash it in front of everybody. So there, I'll leave it at that. And thank you, Faye, for calling in. I see you made it.
I see Stephen Boses did you have your hand up?
Hi, yes, I've got one announcement to share. In March in Salt Lake City is the 4th International Conference on End of Life. First time it's been in this country. I think it's like the 6th through the 10th. I don't have it in front of me. But
6 through 8, I have it pinned up
okay,
here.
great. Thanks, Lynette.
Mhm.
Thaddeus Pope is one of the organizers of this. I'm going out there. I think it should be I'm really looking forward to it.
Hello,
Hi.
Dr. Alex Kahn.
Hi. Thank you so much for putting this on, first of all, and thank you to the speakers who are doing this. I'm super excited about this session, and these are always great sessions. Since we're doing announcements, just to remind everyone, the call for submissions for the American Society for Bioethics and Humanities meeting, which will be in St. Louis this year, I believe, is open, and there's a fairly short window, so it'll be closed in the not too distant future. And folks are always encouraged and invited to apply to those and put stuff together. And certainly, you know, Paula and Lynette have an amazingly strong history of getting stuff accepted. So I just encourage folks to reach out. I'm also happy to chat with anyone about strategies for getting those things accepted. And that's a great meeting if folks are interested in going.
Yeah, and if we get stuff accepted, you'll certainly get stuff accepted. Right, Alex?
No, you guys always put on great sessions. So your panels are always fantastic.
Well,
So
thank
I
you.
think
Back
I
at
think
you.
you know you have the recipe for success. So I
Thank
encourage
you.
folks to
Appreciate
reach out for help.
Okay, Dr. Tomita or Lynette, or Dr. Cedarquist, sorry, do either of you want to introduce our speakers?
Let's have Dr. Lynette Cedarquist handle this. She was, and again, even though you mentioned credit for me for
I
this
wasn't
panel,
prepared for that.
Really, Lynette gets credit for pulling this together. Well, she'll give the background on how this started at UCSD. Well, anyway, Lynette, go ahead, please.
Oh, okay. I didn't know I was doing the introductions. Okay, so let me introduce our panel so we can get going. So we have Dr. Michael, is it Labatz?
Yes,
if I pronounced it correctly. Dr. Labatz is the co-clinical chair of the San Diego Alzheimer's Project and the clinical roundtable that was established by the San Diego County Board of Supervisors. So looks like has been very involved with this issue in the community. We're really happy to have you. And then we have Dr. Ian Neal, who works with me at UCSD and serves on my hospital ethics committee, has been super collaborative and helpful with a lot of things through that committee. He's one of our professors in geriatrics and runs the geriatric medicine consult service in our senior behavioral health unit at UCSD, and has presented on this very topic for our ethics committee within the past year, and was really a fascinating talk. So I'm really happy that Ian could be on this panel as well. And then Dr. Lindsay Yorman is the County of San Diego's first chief geriatrics officer with the Health and Human Services Agency. She was previously full-time faculty in geriatrics at UCSD. So it's great to have her on this panel as well. And then I'm sorry, I'm losing my screen here for some reason. Dr. William Mobley is in our Department of Neurology at UCSD. We kind of asked him to join this panel last minute to fill in for somebody. And so I'm really happy to have Dr. Mobley on this panel as well. So I'll let everybody take it from, go ahead and take it from there.
Okay, let me start. So first of all, thank you so much for allowing us to enter into this hopefully collaborative conversation about treatment of Alzheimer's disease. I've been a clinician for more than 40 years now, and I've seen changes occur in the treatment of Alzheimer's disease over time, including the initial cholinesterase inhibitors like donepezil, and then the others that came after that, and memantine, none of which really worked very well, if at all. And had to deal with many ethical issues over time. And I think every physician that, or a healthcare practitioner, no matter whether it's a doctor, a nurse practitioner, a physician assistant, a social worker, a chaplain, or anybody that has to deal with the issues relating to Alzheimer's disease runs up against ethical issues. Some of those, I'll just list a few of them that we normally deal with in one way or another, sometimes well, sometimes not so well, include things like, do you tell your patient that they have Alzheimer's disease? Believe it or not, that is one of the main complaints to physicians, that they don't, patients don't get to know their diagnosis about Alzheimer's disease or dementia. How do you deal with driving? And what's the ethics there? Because California is one of those states, as you probably know, where we're in between the Department of Motor Vehicles and our patient. And we're actually forced to report them if they have a dementing illness. What about getting consent for treatment? How do you consent an individual who can't remember what you're saying? And what's the method to do that? And how do you ethically deal with that? Then there are new things like genetic testing. Should we be doing that? Do we recommend it? How do you deal with it when your patient goes to 23andMe and comes back and says that they're homozygote for ApoE4? And am I going to get Alzheimer's disease? Now new things are happening. Blood testing is coming. There are already on the market some tests for looking at ratios of certain proteins like amyloid and tau in the blood that are potentially sensitive and specific for diagnosing amyloid in the brain, which is equal to essentially the possibility of Alzheimer's disease. And then finally, and this is the segue into the discussion today, is that we have the advent of monoclonal antibodies. These are new treatments that actually have the potential to be disease modifying, the first time that this is possible in Alzheimer's disease. And for somebody who's been in the field working with patients, and I've done research clinical trials, including on the early monoclonal antibodies, to find something that actually makes a difference potentially for a patient in modifying their disease process is stunning, and has created huge amount of PR in the world. So that's where we've come from, and we started with the County of San Diego realizing about 7 or 8 years ago that Alzheimer's disease and related dementias were a public health problem in San Diego County. And I can't keep up with the number currently, but we're close to 100,000 individuals in San Diego County with dementia. If you think that each one of them has at least one, if not two, caregivers associated with their care, you can see that the numbers are enormous, and it's a significant percentage of the population that are affected by this disease process. So the county recognized this and put together the Alzheimer Project by decree about 8 years ago. And people like myself and Dr. Mobley and Ian Neal and others on this call that I see familiar faces, joined in an effort that was over multiple health systems to try to develop standards for first the screening for memory disorders, then the evaluation and treatment of memory disorders, including the behavioral aspects and how to manage patients if at all possible. And that's been an 8-year project. And I got to tell you, it's like herding cats. Of course, try to get doctors to agree on anything can sometimes be very difficult. But we were able to come to terms and develop these guidelines, which have been published now on our website and have been disseminated really across the country and picked up by other health systems across the United States. So at this point, we're at this, and Bill has talked about this previously, this inflection point, and I'll let him talk about this a little bit more, but change has occurred in the evaluation and treatment of Alzheimer's disease at this point. And the question is, how do we deal with this, both as individual providers of care, as well as a community in dealing with our public health issues, which are so diverse and so incredibly difficult at times. So with that, I'd like to ask Ian to give us, if you could, Ian, just a short overview of monoclonal antibodies, how they work, and what the story is about that.
Yeah, absolutely. Thank you so much, Dr. Lobatz. Having grown up in undergrad in philosophy, I know that one of the banes of philosophy is the PowerPoint. And we really want this to be more of a didactic discussion rather than a lecture. But we do have some information that I think it's important to go over to bring everybody kind of up to speed to where we are with these drugs. What do these drugs promise? What don't they promise? And why are we even discussing this in a bioethics seminar? So I'm going to give a very brief overview of that. So apologies for my use of PowerPoint, but I promise that I will give no more than about 5 minutes of an update. I'm going to set a timer for 6 minutes, since I know I always talk long, and when my timer expires, I will stop regardless of if we're done or not, to leave as much time for discussion as we can. But the reason that we're talking about this is that we've got a lot of drugs, as we've mentioned, that have been approved for the treatment of Alzheimer's disease that unfortunately haven't done much. They've all been targeting downstream targets. And so initially the thought was, well, let's try to target what we think that we know is causing Alzheimer's disease. And we know that there are these monoclonal antibody plaques that are pathognomonic for Alzheimer's disease. And they're a lot easier to target since they're outside of the cell than the intracellular tau. So the thought was, let's start trying to get rid of plaque from the brain. And one of the easier ways to do that is to generate an antibody that binds to the amyloid when it's in the plaque form and triggers the immune system to actually pull the plaque out of the brain. And so this started getting researched over a decade ago. And people were very enthusiastic about it. Back when I was in medical school, they had this race between two drugs called bapineuzumab and solanezumab. And they were giving cute nicknames to them, Bapi and Sola, and everybody was excited about them and thought that these were going to kind of fix the disease. But then in 2012, articles like this started showing up in the news. Bapineuzumab's blow up. The amyloid hypothesis is dead. What happened is that all FDA trials have a futility analysis worked into it, where at the halfway point through the trial, if a drug hasn't shown any trend toward benefit, then the FDA will stop the trial due to evidence of futility. And bapineuzumab reached its futility analysis and failed. Solanezumab also reached its futility analysis and failed a few years later in 2016. Then this drug called aducanumab came into it, and people were hoping that aducanumab would be more effective because it removed a lot more plaque from the brain. But aducanumab in 2019 also reached its futility analysis and failed. But a couple months later, about half a year that is, they went back to the FDA and said, we had some data that didn't quite make it into the futility analysis that when we looked at it, started showing a trend toward benefits. So can we be evaluated not for restarting the trial, but for approval? There was a lot of skepticism about this. The FDA's advisory panel on neurologic drugs actually unanimously voted against approving this drug and recommended to the FDA not to approve aducanumab. But despite that, back in June of 2021, the FDA did grant an accelerated approval for aducanumab for the treatment of Alzheimer's disease. Since then, new one, lecanemab, has also been approved. This one actually got full approval as opposed to just the accelerated approval of aducanumab called lecanemab. And this just got approved last year. And a third drug is also now seeking approval called donanemab to try to also receive approval for the treatment of Alzheimer's disease. So what really happened? Really, what happened is that we saw that these drugs worked. You know, when we looked at them in trials, we saw that the amount of amyloid plaque in people's brains after an 18-month treatment period with the drug was significantly less than not on the drug. So it did what it was supposed to. But unfortunately, there's also side effects associated with this. They can cause these things called ARIA, both hemorrhage and edema. When you bind to amyloid in the brain, you're going to bind to it wherever it is and pull it out. And amyloid does get deposited in the vasculature of the brain as well. So as you pull that out, it can lead to an increased porosity and leakiness of the blood-brain barrier and can cause these things like hemorrhage and edema in the brain. Some of this can be asymptomatic. Some of this occurs just naturally in Alzheimer's disease as well. But some of this can be symptomatic, and especially in aducanumab, it had a very high rate of doing this. 41% of people on the therapeutic dose of aducanumab developed ARIA. About 12% of those actually had symptoms, headache, seizures, confusion, or stroke-like symptoms. But why would we approve it then? Well, really what it is they looked at this thing called the CDR, the Clinical Dementia Rating Scale. And this served as the primary endpoint for the trial. And this is what the CDR is it basically takes a subjective assessment of 6 different subcategories of things that patients with dementia can face and rates them on a scale of 0, 0.5, 1, 2, or 3. And then you sum everything up into a raw score of out of 18 points. And what they did is they tracked the patients on the drug and on placebo and tracked their CDR scores. And what they saw was that in one of the 2 trials of aducanumab and in the only trial of lecanemab, there was a significant slowing in progression of disease based on the CDR sum of boxes compared to placebo, 22% in the eMERGE trial, which was one of the 2 aducanumab trials. But here's where things get ethically a little bit murky, because while that 22% is statistically significant, clinically it's a little bit grayer, because what that actually equates to is a raw point score change of 0.39. So that means not even a change by one single box on the CDR sum of boxes. That's what we call a statistically but not clinically significant change. The question then becomes, this only tested this up to about up to 18 months, but we can see that the curves are diverging. And the thought is, if we continue to treat this, those curves may continue to diverge and we may continue to get more and more benefit with the drug as time goes by until eventually maybe it does reach a clinically significant range. But there's a lot of issues with the drug. It's got a lot of risks and it's got a lot of side effects. The other thing is that it's had a lot of things that excluded patients from the trial. So really all we can say about the drug is what it did to the study population that it was studied in. But all of these are the exclusion criteria from the phase 3 trial, and they're pretty big things. History of stroke, TIA, unexplained loss of consciousness in the last year, any history of unstable angina, myocardial infarction, heart failure, conduction abnormalities within 1 year, impaired renal or liver function. So there's a lot of things that could potentially exclude somebody from this drug, at least in the clinical trials. The other thing is anything that can thin the blood, they also excluded from the trial because they didn't want to increase the risk of ARIA even more. One of the big issues that we have with it is that it's got a very high cost associated with it. Initially, when aducanumab came out, it was priced at $56,000 per year just for the infusion, not counting the cost of the infusion center, drug monitoring, or testing. ICER, a group that does cost analysis for benefit, did a cost analysis of aducanumab and found that it estimated a cost range of $2,500 to $8,300 per year would be the more cost-effective target. Based on that and public backlash, they did reduce the price to $28,000 a year. This is a little out of date. We do know that you have to screen for the amyloid in the brain, and initially amyloid PET imaging was not covered. As of this year, it actually is now covered by insurance. So that's at least one hurdle overcome. And so now lecanemab is approved as well. Most importantly, both these drugs were not approved for all forms of Alzheimer's disease. They were only approved for the mildest stages of disease, as defined by a MMSE of less than or of greater than 22, relatively low functional impairment related to the disease. And with lecanemab, we had a similar story of it had a statistically significant CDR-SB score improvement, but the actual point improvement was only 0.45. It had a lower rate of ARIA, with 12.6% of patients developing ARIA compared to 41. But it also had a 26% rate of an infusion-related reaction to lecanemab. It's priced similarly at $26,500 a year. And it had even more exclusion criteria included in its trial than aducanumab did. For the sake of time, we'll glance over that. But some of the issues that we start to run into with this is that, especially when we have such a high cost drug and a drug that's approved for such a tight range of, or a tight window of time for treatment, is that equity really starts to come into it. Both these drugs, aducanumab and lecanemab, were studied in a largely white population with very few other socioeconomic status demographics known, but the average education of the patients in the studies were also quite high. Aducanumab reported an average education of 14 and a half years. And we know that the cost of these drugs is likely a barrier to care for the underinsured and for low socioeconomic status patients. But also, we know that access to the drugs can be limited because these aren't things you could just prescribe in the clinic. You need an infusion center to give them. You need to have a neurologist for monitoring, a specialist to prescribe it, to track, a pharmacist, etc. And if you're in a rural or underserved area, you're likely not to have those resources. Additionally, we know in marginalized and low SES communities, you're likely to have delays in dementia diagnosis and not catch it when it's in the mild cognitive impairment stage. So a lot of those patients wouldn't be caught until they didn't even qualify for the drug. So there's a lot of issues around equity surrounding this that Lindsay Orman is going to talk about in greater detail. But the other thing to note is that there's a bit more pessimism about these drugs from the geriatricians than there is from the neurologists. And the American Geriatric Society actually submitted a 3-page letter to the FDA back in June 2021, a week before the FDA approved aducanumab, specifically asking them not to approve the drug because of this balance between beneficence and non-maleficence. We didn't see that there were clear clinical benefits to this drug, and the side effects were pretty profound. Not to mention the patient demographic characteristics were all things that were cited in treating these treating this condition. And so while there's potential for hope with these drugs, there's also a lot of issues that start to arise with it from a cost standpoint, from an access standpoint, from a balance of how much do we want to risk harm to a patient for a chance of benefit. All of which I think are really important to be discussed and why we're here today to discuss them. So with that, I went a little bit over, but we'll end the PowerPoint and turn it over to Lindsay to give some more big picture questions.
Sure. Thank you so much, Dr. Neal. That was a really tremendous summary. And I am always eager to get my hands on Dr. Neal's PowerPoints because they are so rich and thorough. And I'm also just really honored and grateful that our neurology colleagues have invited us into this discussion so openly. They have demonstrated so much compassion and dedication to minimizing the suffering of this disease. They are experts, and just as Dr. Neal is, and Dr. Lovatz was correct in that it is a bit of herding cats. And instead of pushing the questions away and the differing opinions away, Dr. Lovatz is the chair of our clinical roundtable, has embraced it with open arms and really has wanted to lean into this discussion about various ethical aspects of the medication. I can just say kind of what triggered a lot of this discussion in our Alzheimer's clinical roundtable was I have spent the majority of my career in clinical medicine and then in academia. And I just entered the county over the last year at the suggestion of my mentor, who is here, Dr. Allison Moore, Chief of the Division of Geriatrics. Kind of exciting that she's here. That the county was, having this position, and there was a need for it, and that I should consider it. So, during this time, I've been in local government now with our Health and Human Services Agency for the last year. I've kind of been having a reckoning of how I view things as an individual clinician treating individual patients right in front of me, with how to think about population health and justice. So in this first year, for example, at the county, I've been spending doing a needs assessment, asking people, what do you feel are the most pressing needs of older adults? And then looking at data about that question. And Dr. Lovatz was spot on with his projection of, we're approaching about 100,000 to 130,000 older people living with dementia in San Diego County. And we know those are usually underestimates because it's the more severe cases or the diagnoses are registered. But in addition to that, I'm seeing that older adults are our fastest growing segment of the homeless population right now. So in San Diego County, we have about 2,000 to 3,000 older adults who are living unsheltered on the streets right now as we speak, amidst all of the rain. In contrast to prior homelessness, or at least studies or stereotypes of homelessness, the bulk of these older adults that are on the streets, at least a majority, it's not because of preceding drug use. It's not because of mental illness. It is that they are literally being priced out of their apartments, hanging on by the edge of their fingernails to pay their rent each month. So that kind of just shook me and made me start to think about every way in which we spend money to promote health of individuals. And it took me back to conversations about equity that we have been having at UCSD and other institutions, and is making me think, what is the individual clinician's role in equity? To what extent do we incorporate justice and the idea of how we are allocating resources to patients for whole health, for whole person health. And to what extent, if a clinician knows that, say, a psychosocial intervention or providing shelter or stable access to food, to what extent of a physician knows that those elements are not being met for their patient, to what extent do we need to question the potential effectiveness of some of these interventions and therapies for people until those vital needs are met? To what extent does our voice as a medical community, to what extent is it our responsibility to be talking about this and to be advocating? People often listen to clinicians because we have that frontline experience. So I have basically been a little bit tortured, and poor Dr. Lorbotz has had to kind of watch me go through this process. But I would really love to hear a lot of what all of you have to say about thinking about medications that cost up to $150,000 a year right now, when you take into account the infusion center costs, the MRIs, the price of the medication. Is it all right to kind of think about, oh, this will be like cancer? You start out really expensive, then you become a drug that will eventually be accessible to more people. Is that all right with our current homelessness crisis, food insecurity crisis, and growing poverty among older adults? So there's that individual clinician question. To what extent do we speak up about these issues? There's also the policy questions at the national level. So Medicare, for example, does not cover personal care services for older adults living with dementia. It's a bad news conversation for a lot of older people. They think that when they grow older and a disease causes late life disability, which 1 in 2 of us on this webinar will have some level of disability where we need total care in the last 2 years of life, and 1 in 5 of us in the last 7 years of life. Medicare does not pay for that. So that is all out of pocket. So if you're a person that, say, and Medi-Cal can pay for it in some capacity, but if you're a person that, say, makes less than $40,000 a year and you do not have Medi-Cal, and you had a choice of how to use that money, say you had the money, how would that person want to use it? Would they want to use it on this drug that has controversial benefit, or maybe a controversial degree of benefit, statistical versus clinical significance, and we hope that it will be much, much more in the years to come, and that it will be just life-changing stories for many people that could benefit from a cure. Or would you want to use it on getting housing tonight and having something to eat tonight? And is this drug going to be effective if given to you? Let's say you chose that, say you did have access to it. Is it going to work if we have unmet social determinants of health needs? So I think I'm going to stop, because I think that I'm truly curious, and I truly don't know the answer. And I'm really ready to hear how a bioethicist thinks through these issues.
And can I interject here for a second? Bill Mobley, could you've done research on Alzheimer's disease for your career and many years, and been involved on all of these things that we're talking about. Can you just give us some of your sort of observations about where we are right now, where we've come and where we are?
Yeah, I can talk about the science a little bit. And by the way, we're giving a course for our neuroscience graduate students on the evolution of ideas about Alzheimer's disease, and really what are the issues and what are the mechanisms of disease. And we recorded these on Zoom, so we could make this available to anybody on this call. I mean, we just would give you a link. So in a nutshell, the biology of AD began in 1984 with George Glinner and Kane Wong at UCSD, in that they isolated a peptide from the brain, from the meninges of a person with Alzheimer's disease, and they sequenced this peptide, and it was really part of A beta, this molecule that forms amyloid in brain. Very soon thereafter, the same peptide was found in plaques in brain by Masters and Bayreuther. And within a very short time, there came out about the amyloid hypothesis. And the amyloid hypothesis originally stated it's the deposition of amyloid in brain that's the problem. This is Hardy and Higgins in 1991. The echo of that hypothesis is exactly what you heard in Ian's presentation, because the focus by those companies is actually plaque clearance. Plaque clearance is what those antibodies do. They do it very well, actually. The question really is, in modern thinking, where does the plaque stand in the pantheon of possible sources of misery in brain that cause neurons to be dysfunctional? It's not the plaque anymore. We know now, almost certainly, that what goes on in Alzheimer's disease is not A beta in plaques that causes your brain to dysfunction, but A beta inside the neuron or in the nearby environment of the neuron, causing synapses to fail. So we're in this inflection point that Mike talked about earlier. We're at the point where modern neurobiology and neuropathogenesis in AD is catching up with the idea about how we target Alzheimer's disease. So as really uncomfortable as we are right now in this conversation with the cost of a drug, with limited efficacy and significant side effects, I don't want to walk away from the ethics discussion here. It's the very important one to have. But I want to create for people a different look at the future, in which not very long from now, we will have pills that people take that are effective, that are cheap, and that'll have very little side effects. That's the prediction. It's not going to happen tomorrow or the day after tomorrow. But I think as we have this discussion now, let's think about having a discussion and dealing with ethical issues around the idea that soon some of the things that are pushing the argument now around cost and efficacy may well be resolved by the better science that's now being done to deal with the so-called amyloid hypothesis. Having said that, I'll come back to the point right now. Where we are right now is a very uncomfortable place. We've got a fatal illness impacting a large population where there's unmet need for therapy, and where the existing therapies that we have today are not very good and are extremely expensive and are risky. So good that we're in this position right now so that we can think about the ethical demands, the ethical constraints that we have to deal with now, so that at some better time, we'll have worked all these ideas out. And we'll know better then how to link the science to the care of people ethically and powerfully.
Well, thank you, Bill. I think we could open this up for discussion and hear from our colleagues in people present in the audience to really pose your questions here for us, and to have this joint discussion about what this all means. I mean, one question could be, why should we do this at all? Okay, and should we just not even bother? Another question could be, should we ration this in some way? And just to those who meet the only criteria for it. And how do we deal with, of course, this inequity that exists in our population that is so striking that Lindsay has talked about? So let's open it up.
Okay. And Dr. Lobatz, I think you posed some great questions. Just logistically, if we can use the Zoom, if you go into reactions, you'll see you can raise your hand. And if you don't see the app, maybe put your camera on and raise your hand. Well, I have a question. Maybe I'll start it off. I'm not a physician, and so I had a question for Dr. Lobatz.
Yes.
You said in the very beginning in your narrative that you found extreme benefit. You've seen benefit in your patients. And while I was listening to Dr. Neal and looking at the slides, he talked about benefit, but he said that, if I understand it correctly, that it's perhaps looks like statistically there's benefit, but it's less perceptible from a clinical standpoint. Did I hear that correctly?
Yeah,
And
I'm not sure you did, or maybe I misspoke, but I have longitudinal experience with monoclonal antibodies dating back to when Dr. Neal was in medical school. So, doing research on the bapineuzumab trial. And at that time, one of the criticisms of that trial was that ultimately came out was that it really took all comers. It wasn't early onset Alzheimer's disease. It was actually moderate to severe Alzheimer's disease, which is probably too late to actually treat patients. But in terms of, I haven't really given enough medications with the current group of meds because they were just approved to actually tell you from a clinical experience that I've seen great benefit.
I see. Okay.
If I said that, I misspoke, and I apologize. But what I do see is that there is a difference between the treatment and the placebo group, and that as time went by, it widened. Okay, and Dr. Neal made the point that we don't know what this is going to look like at 24 months, at 36 months, at 48 months. We have no idea. And we're going to learn that because Medicare, if they're going to pay for this, is going to require patients to be enrolled in a registry so that we will be able to generate data and actually ultimately find out the answer to that question.
Okay.
And then the other thing is that, you know, I've had this conversation, and maybe others in the audience have had this conversation with their patients who come in and say, after we've diagnosed, let's say, mild cognitive impairment due to early Alzheimer's disease, we're still functioning pretty well. And you talk to them about this, and it's really interesting. Certain individuals, particularly I would say some physician colleagues that I've had the occasion to diagnose them with Alzheimer's disease, are interestingly not interested in getting the drug whatsoever. They are nihilistic about it because they are saying, if I'm only going to get, you know, when those curves crossed, it was about 8 months of benefit for 8 months. And so I'm not interested in that. And then I've had other patients who are reasonably high functioning who go, give me the drug, doc, as quick as you can. I'm all in, 100%. I've had all of those conversations and those in between. So the thing that bothers me most about it is obviously the cost, but also there's a burden to do this treatment. You have to be infused. I don't think Ian mentioned this, but it's twice a month. You're in an infusion center getting an IV currently. And you have to have an MRI a few times to check for ARIA. And you have to be diagnosed properly to begin with. And then you have to be careful that you should not give this drug to people that have a tendency to bleed in their brains. And there's ways to detect that. So there is a lot of issues, but
Okay.
we're confronted with the individual sitting in front of us. And speaking to Lindsay's point, which is, you know, how does the individual clinician translate that into the societal benefit or problems that occur from using this? And I certainly don't have the answer to that. I'm still doing one at a time medicine, you know, in my practice. But I am open to discussion about this, and I welcomed Lindsay's real advocacy for the population. And I would really love to hear how we should handle this. Really, I don't know the answer to that.
So it looks like we have Dr. Heikoff, then Dr. Cedarquist, then Dr. Yorman. I am going to insert something given that I'm facilitating. Dr. Lobatz, I hear the moral distress because we know we should never be rationing care at the bedside unless we're under crisis care conditions. So the context is such that it's out there for use and your obligation is to the patient in front of you. Dr. Heikoff.
I'll try not to say everything that's on my mind here, but first of all, thank you to everybody for this discussion opportunity. I've always been of the mindset that the amyloid, you know, involvement is just one part of the cascade of things that result in Alzheimer's disease. And I think as we see the research, there, just like with cancer, breast cancer is no longer breast cancer. There are many, many different types, subtypes, genetic subtypes, treatments vary, outcomes vary. And I think as the research goes along, this is going to turn out to be a much more complex pathophysiologic process, and treatments are going to have to be, you know, customized to different types of dementing illness. So that said, when I hear people talk about, you know, making a decision about the individual patient, how different patients' reactions are about whether or not to proceed, this sounds just like cancer treatment, doesn't it? I mean, you know, when we offer somebody a palliative chemotherapy that may extend their life by 8 months or a year or two, with suffering that goes along and side effects that go along and scans that have to be done and infusion center visits that have to be done. I mean, this is really kind of the same model of care, isn't it? And yet somehow or other with cancer, we're like, oh, you know, it's the big enemy and we got to fight. But with dementia, we sort of, you know, oh, you know, there's this inevitable decline and it's going to be terrible and you might as well just give up and not bother. So I'm of two minds about it. On the one hand, because of people's willingness to subject themselves to cancer treatment, we've gained information and refined cancer treatment over the years. We're still doing it. It'll probably go on forever. And I think treating people with monoclonal antibodies will help us refine our understanding and treatment of Alzheimer's and related dementias. And people will make individual decisions, just as they have, you know, for cancer. The larger question of where we put our dollars in this country between healthcare and the social safety network and food and housing, I mean, that's such a large political issue, and we have segregated medical care, and you know, I won't go into the whole, you know, medical pharmaceutical complex, but we've really segregated medical treatment from other forms of care in this country, and that's just a very much larger, political issue. So I don't think that's something we're going to solve with decisions about a particular treatment for a particular disease. Certainly with cancer treatment, those same issues, prevail.
Great. Dr. Cedarquist?
Yeah, I think a lot of what I was thinking about, Lisa just outlined, but I'll just add, I agree. There's a tension between what to do with the patient in front of you versus looking at it from a societal, community-wide perspective. I think treatments like this, I think, are what feed into the statistics of healthcare in America in general, that we have the most expensive healthcare in the world, and we have some of the worst outcomes because we live in a society where the basic needs aren't guaranteed. So you could have somebody who's living out on the streets, or you can have somebody that doesn't have anybody to take care of them at home. They can't afford expensive care, but then you have these, super high cost novel treatments that we pour money into. And an interesting thought, when Lindsay was outlining all the challenges of the cost of care of dementia, if Medicare was willing to pay for that person to get a drug or a treatment that costs $120,000 a year, wouldn't it be an interesting model for Medicare to say, well, we can spend that $120,000 on this drug for you, or we'll just give you the money for your dementia care. Of course, that'll never happen, but it would be a good model. The other thing I want to comment on, and then I'll stop. It's interesting to me to see the long list of exclusion criteria in the study. And then when it gets approved to go on the market, there's no contraindications listed. And that, I find that very troubling. I don't know if anybody on the panel wants to comment on that issue. I didn't really realize that, but that seems really problematic.
There were a lot of problematic things about the rollout of the package insert for the drugs. The first day that the package insert came out for aducanumab, for instance, the package insert said that it was approved for the treatment of Alzheimer's disease. And there was immediate backlash, lots of letters written angrily to the FDA. And then about a week later, they revised it and said it's only for mild cognitive impairment due to Alzheimer's disease and mild Alzheimer's disease. Similarly, there's been backlash over the contraindications. The benefit and kind of the thing that I've been really impressed by is that despite the kind of cavalierness almost of the package insert, there has been a lot of responsibility taken from individual providers and from insurers in that, when you actually look at once it got to CMS and its approval and to the individual insurance's approval, they all immediately turned to the FDA phase 3 trials and to the contraindications that were used to exclude people from the trial and included those as contraindications for the drug. So while it's not on the package insert, it's a contraindication to get it approved by insurance. So that's been the promising thing. And that's kind of the hope of, how government and control works, is that we'll have responsibility at lower and lower levels, but the risk is still there. And the issue that I've had with that risk and kind of, talking about access, for instance, is that when this drug got approved, there was a lot of misinformation, and there still is in the news about it, of new drug for the treatment of Alzheimer's disease. People see it on the news, they bring it to their primary in an article, and their primary auto refers to neurology to get evaluated for the drug. But they may have a MoCA of 14 and they wouldn't qualify for the drug anyway. And we already have a massive backlog of wait list for seeing neurologists. I'm looking myself on geriatrics at like a 6-month wait list to be seen. Our neurologists are all at least 6 months. Neuropsychiatry is a year-long wait list at UCSD right now. And so with a wave of increased referrals of people wanting to get this drug, that can further limit access to care. And that's why I've been so passionate about speaking about it and generating these talks and talking to primaries about it, is that we hope that through the Alzheimer's Project, we can start having this, at least some basic education about this drug at less specialized levels, so that way it can try to help us have those conversations with the patient before we refer, to truly refer only if it seems like it may be beneficial. Is kind of my 2 cents on it.
Yeah.
Dr. Uhrman, yes.
Yeah, no, I'm so grateful to be here because I already have gained some helpful frameworks in how to think through some of these questions, both from the clinical level, but then also population health level. And I just be really curious to hear the group's response and thoughts to 2 questions. One is, okay, thinking about it at the individual patient level. I'm a clinician, I'm counseling a patient, talking about risks and benefits. And how would you explain the benefit of this drug today, not to the future research community, but today for that patient sitting in front of you? For example, with the donanemab trial that just has been underway, and we saw that out of a 144-point cognitive scale, the drug group declined an average of 10 points over the study period time, versus the placebo group declined by 13 points. And the difference between the drug and the placebo group, again, 3 points on a 144-point cognitive test, that difference is smaller than the total decline that occurred for those patients over the duration of the study period. So how do you explain this to patients? Okay, so bottom line is, it's a small benefit that we've seen. Who knows, maybe 5 years down the line, or if you started a lot earlier, maybe it gets a lot bigger, or maybe just tweaking the drug, we get closer to what we've seen with cancer, where you eventually get to a cure with a lot of these medications. And dementia definitely deserves as much attention or more, let's not compare diseases, but anyhow. But how do you explain that to the patient in front of you in a transparent way? And then how do you explain that, it's not curing the disease, it's not reversing any symptoms, it's actually just going to slow your decline. To someone with low health literacy, how do you help them make an informed choice? So that's my first question to the group. I'm curious if anyone has any ideas, because it's confusing to explain to clinicians. So okay, so that's number 1. Number 2 is, now thinking at the population level, as clinicians or leaders or community members, there are things that we know that there are things that have been studied for dementia, comprehensive care dementia models, that actually have shown evidence of benefit. They're psychosocial interventions. I'll just post a little chart of them right here. Things like caregiver support and respite and education and different types of activities and meaning making and legacy projects, and Bastings has a whole line of work. These interventions have been shown to improve quality of life for patients and for caregivers. And recently we heard about hearing aids also reducing the risk of cognitive decline by 50% and high-risk patients. Should we have equal excitement and investment in these models, and should we be advocating that our healthcare systems, should we be advocating more for an infusion center and good protocols to enroll people to get access to these drugs, or should we be advocating for a comprehensive care dementia model? And actually, it's not just a theoretical thing now, they're actually out there. The GUIDE model is going to go live. I just posted a link, and I'm not advertising for it. The time to apply for it has really passed. The applications are due January 30th of 2024, but health systems have the option of applying for alternative payment models like these that are investing in social determinants of health as well. So, okay, I'm going to stop, but I would love your thoughts.
Okay. I did raise my hand, and I see Dr. Khan also has his hand raised. So, Dr. Yerman, I do have a question for you as a clinician. Do you feel morally neutral about what the right action would be for your patient? And is that what you're striving for? And, you know, when we practice medicine, again, I'm not a doctor, but sometimes we tend to overuse the menu approach. Like, this is what's available. So I'm assuming that you probably have an opinion. And do you struggle with that? I guess that's kind of, so I needed to ask that first.
No, that's a really great question. So I did clinical work up until November 2022, and I'm restarting it at the VA next month. So I have had the liberty of not being faced with this in the office as, direct to consumer advertising is about to hit. But I personally, I probably would say, it always depends on the patient, their values, their priorities. Different people are willing to take a different level of risk for a different probability of benefit. And what is a benefit and what matters to them is different for everybody. But I would reserve an entire visit just to talk about risks and benefits of this medication, because it is really hard to understand. I would try to use visuals. I would try to, really make sure that the patient understands that we don't have an answer yet of how their life trajectory looks different in 5 years if they took this drug or if they didn't. And so some patients, as Dr. Lovatz was saying, that they'd be okay with that. If there is a chance that this works, is on the verge of something in 5 years, maybe we'll see a undebatably meaningful clinical benefit. Right now, I think the clinical benefit is somewhat debatable, at least between, geriatric society and neurology societies, and from what I've seen from the different debates out there. But I would still offer it, but a really thorough explanation of the limitations of our knowledge about it. I hope that and most importantly, I would definitely offer some of the things that we know that work, such as emphasizing, please call the Alzheimer's Association, please call San Diego Alzheimer's to help get equipped with some of the community-based resources that have been shown to improve quality of life in this medication. That's probably the most important thing that even more important than talking about all the nuances of the medication is these are the things we do know that improve quality of life, and here's how you access them.
Thank you for that. Dr. Khan, then Dr. Chung, I hope I'm pronouncing your name correctly, and then Dr. Hykoff.
Thanks, Paula. Sorry, my camera is not working. So I wanted to touch on this question that Dr. Yorman raised of, well, what do you say to patients to adequately inform them, right? And it was interesting to me because Dr. Lovatz had mentioned that in his experience, lots of physicians, when confronted with this, say, I'm super not interested, right? And it's interesting, and I hate to go back to my own field, but that's what I know. And so one of the things that I have found really interesting, there was research done for this horrible congenital heart disease called hypoplastic left heart syndrome that showed that if you talk to physicians who care for these patients, a third say that they would want, for their own child, they would want surgery. A third say that they would want palliative treatment and end of life care and no surgery. And then a third said, I don't know. And what was really interesting to me is when parents were presented with those data, it was super impactful to say, you know what? Doctors who do this are really split. It seems like about half would want it and about half wouldn't. And it completely changed their perspective, because to them it was like, well, this is the only option, so of course I have to go for it. But when they hear that actually experts in the field, when you ask what they would want for their own kids, it's really different. And what I would say would be super interesting is for you folks who actually do geriatrics and take care of these patients in neurology to actually do some research looking specifically at that and comparing the general population to patients who present who have significant healthcare experience, like doctors, nurses, etc. And look at that, because I think if there is this great tendency among healthcare professionals who really understand this to say, that's not something I would want, that's information that I think patients and families would both want and really benefit from, because it would help them put it in perspective. Because we know if there's no other option, patients pretty routinely say, well, I want whatever, whatever option there is, even as horrible as it might be, because it's better than nothing. But if they hear, well, actually, maybe it's worse than nothing, and here's what the experts say, and a lot of them think it'd be worse than nothing, I think that could be super impactful.
Yeah, thank you. Dr. Chung.
Yes, thank you. First, a quick comment and then a question following that. Dr. Yerman, congratulations on your starting work at the VA hospital. I understand that they were one of the first to approve using lecanemab as treatment, so I'm sure you're going to have lots of those conversations with patients there. So congratulations or condolences, whichever is more appropriate. Dr. Neal, you had a really nice slide with all the contraindications for using lecanemab, but it was only up on the screen very briefly. If it's possible, could you just put it up again? And considering how long the contraindication list is for using lecanemab, I'm just curious to know if anyone has an idea as to how many patients in San Diego would be even eligible for this treatment. I know that we have a really good question. Yeah,
I will definitely share it again. But yes, when you whittle down to who actually qualifies, it becomes pretty hard to find somebody that actually does qualify for it, at least by the guidelines. And one thing we're seeing, for instance, is that they used an MMSE of 22 as the cutoff. Yet even there's controversy about, well, what about MoCA? MoCA scores are typically lower than MMSE. And what's the MoCA cutoff? And there wasn't one in the research, so people have just spitballed it. And, I've seen some insurances say, well, maybe MoCAs as low as 12 are okay to give. And other insurances have said, maybe a MoCA of 18 should be the cutoff. But there's no right answer for that. And so despite having all these exclusion criteria, there is still a lot of gray zone about who this is going to be prescribed to. And I have a feeling we're going to still see it prescribed to a lot of people that didn't fit the inclusion criteria for the trial. And what will that do to both the potential benefit for them, to the risk for them? We don't know. Time will tell. And as long as they're in the registry, hopefully we'll know. But that is a very important and salient question.
Yeah, so the thoughts that are going through my head is that when we're counting the numbers of people who have dementia and Alzheimer's disease, it's overwhelming. But using these contraindication measures, the numbers may be whittled down to make it a little bit more manageable. And I do have my own concerns about not there being a great efficacy in terms of treatment result. But essentially what it does do is slow down the pace of the disease. And as Dr. Mobley suggested, we will get better treatments down the line. But as the disease progresses, the patients will no longer be eligible for the better treatments in the future. And so when patients are qualified to receive the treatment, I think we really should consider it and offer it if there's the means to do so.
I was going to make one comment also that I don't believe that there was any difficulty in recruiting patients who met the criteria for this treatment. And that's probably because of the overwhelming number of patients that are out there. And then when you screen specifically for mild cognitive impairment, that would be an MMSC of 22 to 26, even a normal MMSC. You are going to be limiting the number of people that have a lot of comorbidities that would otherwise take them out of the picture.
Right.
To err on not screen sharing for too long, I went ahead and just took a screenshot of the risk slide and sent it in the chat, so everybody has access to that if they wish to peruse it at their leisure.
The Dr. Lobatz, you had also brought up a good issue before, that there isn't trouble finding a certain demographic of people to take this medication, but the studies did have a lot of trouble recruiting people from underserved communities, from different races and ethnicities. Women, the study age on average is 10 years younger than the older adult that has mild dementia, than the average age of the older adult with mild dementia in the United States. So
Yeah.
we won't have trouble filling the slots. I agree with that as far as demand. But the question is who? That's the second equity question.
But I'm going to point out that that's the problem in almost every study that I'm aware of.
Yeah.
Equity within the research itself is a problem. Gender, race, things like that. So
I think it's that the geriatricians feel they have some kind of, like, we can't comment as much on cancer because we just don't know the biology as well and don't see patients for that specifically. But I think now that this is something that is at least close to our domain, we feel compelled to engage in those discussions. But you're right, that's all of medicine.
Dr. Hykoff, and then Dr. Mobley, and then Dr. Shankar.
And then that should probably be our last three, just keeping a watch on the time.
Yeah.
Okay, I'll try to be quick since I already spoke, but I think this is going to turn out, this type of treatment is going to turn out to be not a geriatric treatment. I think that the Institute on Aging and Alzheimer's Association kind of came out with some proposed new classifications last year, suggesting sort of really, really wrapping around the preclinical phase of this disease, and that's going to be the most impactful place to intervene. This is maybe going to turn out to be something that we screen for in early middle age, and that the treatments that Dr. Mobley is, predicting will turn out to be things that we're not giving to geriatric patients, but perhaps to middle-aged patients, much like we do statins at the moment. So, I think things are going to change. The other comment I was going to make was just that this question hits all of the major principles of ethical consultation or ethical decision-making, autonomy, beneficence, non-maleficence, and that's a narrow margin with this particular treatment. And then, of course, the justice issue, which Dr. Yerman has spoken to. So it's a pretty classic topic for an ethics discussion. I just wanted to mention that. Thank you.
Dr. Mobley?
Yeah, just briefly to piggyback on what Lindsay's talked about. We know that 40% of the risk of AD is modifiable. And the cost of intervening on those modifiable risks is very low. Maybe the most expensive is providing hearing aids for a patient, but enhancing social connectivity, treating depression, counseling about blood pressure control, diabetes control. These are things, motivating people to exercise. These are all things that are really quite inexpensive. And I think at least half of those, maybe more, there's epidemiological data that says it's more impressive in reducing risk, or perhaps differently, ignoring them increases risk more than this antibody treatment slows progression. So I think something that serves justice is to make sure that all of our patients know about these modifiable risks, that we bring them up with all of them, whether rich or poor, and that we promote this as one way to keep your brain very, very healthy while the rest of the field develops even better therapies to target and prevent Alzheimer's disease.
Amen to that. That's how I always wind up ending my lectures on this, is that, we're trained as physicians to give meds, and we're trained to talk about meds, and we spend hours upon hours talking about medications with patients. But these non-tangible interventions, the amount of benefit that social interaction and physical exercise and mental stimulation can give, can often be significantly more. But we spend so little time in comparison talking about it that in and of itself is sometimes doing our patients a disservice. It's why I always tell my patients during clinic that the Dr. Neal prescription for memory is exercise and get a hobby. Kind of the more mentally engaged you are, the more stimulated your mind is, the more that you are physically active and interacting with others, the better off you're going to be, the higher your functional level is, and the slower that decline is going to be, just because you've raised that starting point. And that can often give us much more benefit than these meds do. But we do have to discuss these meds, for better or worse.
Okay, Dr. Shankar, and I think I saw your face.
Yeah, I did briefly pop on, but I'm going to take this off video for.
Okay.
But I'm curious, and I followed some of this discussion around the FDA panel about approval of this drug, and I was quite struck by how much patient advocacy played into the role for actually approval, or the extended accelerated approval that adlizumab got through the FDA. So I was curious if the panel wanted to comment about the impact of patients in this process of getting drug approvals in the absence of, or in the absence of meaningful clinical data to support it. And that was question one. And the second thing is more a comment to what Dr. Neal said. I'm a practicing pulmonologist with a very large panel of patients who are elderly, who I have the same prescription of please exercise, please go out and have social connections. But I also recognize the challenges that our own community has in doing that. A large number of my patients, as they get older and have lung disease, are limited in their capacity to get out and drive. We as a community do not have set up for people to get to social networking, so to Dr. Yerman's point, I think as a community, we should invest in trying to be able to get our older folks into settings where they could engage and interact, develop a hobby, particularly for the lower socioeconomic groups, where this prescription that I write many times is also not actually conducive or feasible to accomplish without the help of a family member who might be working long hours. So if there's one thing that Dr. Yerman, that is in your power to influence, is let's look at ways that we can get our community more engaged and more interactive, with less ability for less disadvantaged patients accessing some of those exercise gyms and social networking support.
Thank you for that, Dr. Shankar. I see we have, I think, Lauren, you will be the last comment, and then I think we'll have Dr. Cedarquist close, summarize. How's that?
I'm sorry, is somebody coming before me? Paula?
There is.
No,
You're,
it's you.
you're on. You're
It's
on.
you.
Okay, all right,
Yeah.
thank you. So where Chaplain lives, because I'm chaplain at UCSD and retired from Scripps Green. But even currently where we live is, well, we're gathered around a end of life patient with family. They would give their eye teeth for one more moment of clarity. Just one, a bounce back, something where they could express themselves and actually see everybody and know that they're loved. So sometimes for one experience, people will jump through all kinds of hoops. And then some people wouldn't take it. They just said, okay, let's let them go. They're in too much agony. We don't need a bounce back experience of clarity. But people who were on the street and homeless, it's hard to get them to take psych meds. Can you imagine having them show up at an infusion center? I'm thinking the ordering of priorities. And by the way, I'm expressing opinions totally, okay? It's not just mentioning, different principles of bioethics, but to put them up front when it's so restrictive already, even for the population that could get to and from an infusion center, they need to come later when it's really proven that there's a big impact and not a small impact, and lasts longer than 8 months. And we have more longitudinal studies. And then we practice on a population that we can actually get, good determinants of. Okay, and if all that's really great, well, what are the other factors that we're not dealing with if it's not the amyloid plaques that are totally responsible? So I'm in for an ordering of priorities among all the items of justice and all the other principles that are involved in bioethics. Thank you.
Okay, thanks, Lauren, for those thoughts. All right, so I think it's time to wrap up to respect everybody's time. I really want to thank all the panelists. You gave us all a lot of food for thought. This is something that I think myself and many of us have been kind of grappling with, how to come to terms with these issues of highly costly therapies. And you're right, it's not just the treatments for dementia, very much is similar in other realms such as cancer care. We're kind of just using this as a specific example of these issues that we grapple with more broadly in medicine. But I think we all came together on the idea of what we should be doing in this setting and many other settings in medical care is focusing on trying to maximize the very basics of meeting people's day-to-day needs and optimizing their self-care. And then we can, start to explore the option of some of these more costly therapies. But anyhow, such a great discussion, and thank you all for calling in, and thank you for our panelists. I think it was really wonderful. So I think before we wrap up in the next 3 minutes, we just want to take a couple minutes to give people a chance to throw out any ideas for future topics.
I have a quick question or suggestion for our panelists. Dr. Kahn had said earlier, our American Society for Bioethics and Humanities, there's still a call for papers, call for abstracts. This really would make a fabulous panel. And so something if we want to continue this conversation offline, but you'd have to be willing to go to St. Louis. So we might meet you in St. Louis.
Yeah.
Is
We
Medicare
can't-
going to pay for that?
Yeah, I was going to say, we don't have funding for that.
No funding. We'll rent a bus. How's that?
We'll treat you to dinner if you make it out there.
Okay, so topics. Any topics? And Lauren, I see your hand is still up, but is that an old hand? Yes.
All right. And if you don't think of something right this minute, but you think of something later, always you can email me or Mitz or Paula with ideas.
Yeah. Nothing's burning.
I do have one burning thing, and it really kind of brings home, I think, what we're all talking about, and it's a model to think about in terms of neuro palliative care. And I almost throw in psychiatry and social work in there too. There could be a lot, it could be a very, very long word. And I will post that paper in the chat, in that image in the chat, as soon as I can do so before the clock strikes 7:30. Let's see, can I do it? Okay, did it work? Okay, it did. So it's a thought piece, and just where I just kind of encourage people to look is a table that kind of shows, what are all the important components of caring for someone living with and suffering from dementia, including pharmacology and the potential for that to help people. So just kind of, I think that there's a lot of collaboration, even though we, all may have slightly different opinions. But big picture, we can do better. And I think this is a good group for that.
Thank
And
you
also
so much,
know
Lindsay.
that you all are now invited to join our commission as well. We'll keep you on our distribution list. Dr. Heikoff, you always have great ideas.
Just one last thing, and that is something that's always been a personal kind of bugaboo for me, and that's our transition in the medical community to open notes. And I don't know if the commission has have you addressed that as a group?
No,
but how the medical systems are doing that, what the implications are for people, the whole issue of communication across all of these platforms, and how that has impacted medical care and the perception of medicine by the public. So that's just an issue that has come up for me multiple times. So
great suggestion.
Yeah.
Lisa. Yeah.
Might be interesting to compare between systems.
Okay. Yeah, we can look into that, and that might be a great topic.
Hey,
All right.
researchers, are you listening? Dr. Moore, are you writing this? I know you control a lot of research at UCSD. Okay.
Yes. I will. I will.
Okay, we are 1 minute over. Thank you so much for joining. Thank you to our fabulous presenters, and we hope to see you at our next meeting.
Thank you.
Yes,
Take
thank
care,
you all.
everybody.